Medical Mariner, Inc.
Ladies and gentlemen, coming to you live from our Norfolk studio, home of the Atlantic Fleet, Medical Mariner, Inc.
Hello and welcome to Medical Mariner, Inc. I'm your host, Paul Stewart. This podcast is going to cover my journey in life, some things I have learned. We will talk about medicine, about PA school, about changing careers, about tattoos, and scuba diving, technical diving. Might even talk about skydiving in there, growing things, resilient living, training, anything else that comes to mind. I will attempt to get some folks on here now and then to talk about things with us, and we'll see where this journey goes. Thanks for listening. And now here's today's episode. Hello and welcome to today's episode of Medical Mariner, Inc. This episode is called Emergency Medicine. I do want to start out by saying, please do not construe anything in this podcast episode as medical advice. To get medical advice, you actually need to be evaluated by a medical practitioner, and you need to have a physical examination performed. If you believe you are having any type of medical problem or a medical emergency, then please go to your nearest emergency room, primary care provider, or urgent care as is appropriate and get the correct advice and care that you need. I will actually be doing an episode at some point talking about the differences between telehealth and urgent care and emergency medicine, and I'll probably add primary care in there as well, just to kind of talk about when it might be more appropriate to go to one versus the other, because having worked in most of those environments, I have a few thoughts on when folks should show up at one and not the other, because there seems to be some level of misunderstanding out there in the wild. But anyway, so I actually got my start in emergency medicine in Hampton in March of 2022. I have been practicing emergency medicine off and on ever since. I did have to take a short break from October of 2024 until February of 2024 because I had an injury where I dislocated my shoulder and had surgery, and based on the advice of my surgeon, I was out of work for a little bit, trying to let my shoulder recover so I'll be able to continue to do things like dive and work in emergency medicine. This is one of the reasons your financial advisor advises you to have enough money on hand to pay your bills for a long amount of time. We had some cash on hand to be able to do that, and that's the only reason we've made it as long as we have. But one of the good things is it also gave me the time to be able to come on here and talk to you guys. And don't forget to thank Jeff Samsel for that, and go over and listen to his Beekeeping for Newbies podcast, since he's the one who started the idea in my head that I should be doing this anyway. But I did start in emergency medicine in Hampton and worked down there just for a short amount of time, primarily because the contract holder with the emergency department changed hands. That probably bears a little bit of explanation. When you go to a hospital, one of the reasons that billing is so complicated in America nowadays is there are lots of layers of organizations that are getting paid for you being there. The hospital often employs the nurses and techs and things like that, and they often supply the medicines, the dressings and things. However, they usually don't employ the providers. A lot of times those may be independent providers, although that is becoming more and more rare these days, that have their own billing structure and fees that they collect. They also have provider groups, which are either privately owned practices or they may be commercial businesses that also are billing for the services that you provide. And that's usually who employs practitioners like me. And that's how you get the care you need. So that's why it's a little bit complicated when you do that. This isn't a discussion of all that. This is going to be more of a discussion about what goes on in the ER, what kinds of things I was expecting going in as a practitioner, what kinds of things I actually ended up seeing, and If you're not a practitioner, you're not in medicine, maybe this will help you understand a little bit more about what we go through in an emergency medicine setting and what kinds of things we see on a daily basis that may or may not be what really we should be seeing in an emergency medicine setting. Part of that, when you think about it, is, what is an emergency? Typically, we define an emergency as, are you going to die, or are you going to lose a limb, or suffer permanent dysfunction if you're not treated right now? A lot of the things that we see in emergency medicine don't fit that category, but we end up seeing them because we have to, and we'll talk about that here in a second. But when I was going into emergency medicine, I did expect that we were going to see a lot of the minor cases of things that really should be dealt with and need to be dealt with right now. Things like abscess, incision, and drainage, minor foreign body removals like fish hooks. Had a guy who had a wire fish tape stuck in his hand one time. Things like that, suturing, lacerations, minor fractures. Those are all some of we consider them minor problems, but they are things that need to be handled right away because they're not going to heal so well, or you might end up with some dysfunction if we don't take care of those pretty quickly. Other things I also expected was seeing some major cases, things like appendicitis, kidney stones, people with pancreatitis where they get some pain over here kind of on the left side because their pancreas is acting up for a variety of reasons. They might come in with a good case of cholecystitis where their gallbladder is acting up. And then your basic cardiac, pulmonary issues, things that are truly life-threatening or could be life-threatening if they're not handled pretty quickly. Also, major trauma accidents. Frankly, working in a level 1 trauma center like I did not do a lot with those because your trauma team and all your consultants are there ready to take care of that for you. So if you are a practitioner and you do have your EMTALA certification and you're thinking that you're going to do a lot of work on some of these bigger trauma cases, getting into a level 1 trauma center is not where you're going to get to do that. You need to do that more in a rural community hospital setting where you're going to be the one who sees them first and stabilizes them and sends them to the trauma center. Most likely you're not going to be getting that job right out of PA school. One of the things I didn't really expect, but now feel like I should have when I got into emergency medicine, was just the sheer volume of the very minor cases, things like sexually transmitted diseases, urinary tract infections that have not progressed to a major issue yet, people coming in for medication refills, the sheer volume of psychiatric cases and substance abuse cases that come into the emergency department. It is truly amazing the amount of that we see. Now, those people they need help, but the way we have emergency medicine structured, it makes it super challenging to help them in ways that are probably appropriate for the things they need. We also get a lot of people coming in for detox therapy, and unfortunately, those people often come back multiple times because that is a very challenging process to get a handle on. So we do get to see some of those folks more than once, and we get to know them fairly well. And sometimes it's a little bit challenging dealing with them because they're in a tough situation. And that's one of the things I think we could do better as American practitioners. Now, earlier I alluded to the fact that you get some cases that come through an emergency department that might be better served if they go somewhere else. One of the reasons we go ahead and see them is because there is a law called the Emergency Medical Treatment and Active Labor Act. This was enacted in 1986, which also happened to be the year I graduated from high school. At about that time, about 250,000 patients a year were being transferred out of or discharged from hospitals simply because they were unable to pay the bills in the private hospitals they were being seen at. At that time, there were about 6,965 total hospitals in America. 3,322 of those were not-for-profit, 730 were for-profit, and 2,913 were government-run hospitals. So Back in 1986, when this law came into being, most of your hospitals were either government-run or not-for-profit. Today, we have 6,120 total hospitals in America. 2,987 of those are not-for-profit, so the number of non-for-profit hospitals has gone down, and the total number of hospitals has gone down a little bit too. However, we have almost doubled the number of hospitals that are for-profit institutions, 1,219 of them, and there are now 1,130 government-run hospitals, so almost half the government-run hospitals that used to exist back in the day. So there's been a big shift in the business model of those hospitals, and without EMTALA, we'd probably have a bigger problem with folks not getting the care they need because of their inability to pay the bills. With EMTALA, if a hospital gets Medicare or Medicaid reimbursement, which is all of them, they have to provide a medical screening exam for anyone who comes into the emergency department, regardless of their ability to pay. So you walk in the door and you say, I need a screening exam. We're going to do one for you. And you can't transfer them out of your hospital unless you are unable to provide the needed treatment with the resources you have available in your hospital. If you are going to transfer the patient to another hospital, you need to make sure they're stable before you transfer them. Now, this does create for some interesting situations. As I stated earlier in the emergency room, our primary goals are to make sure you're not going to die, you're not going to lose a limb, and you're not going to be permanently disabled. With the advent of some of the changes that we've made in healthcare laws, a lot more people have access to the system nowadays, but there haven't been a tremendous growth in the amount of primary care providers and things like that are available. So there are a lot of people who are not getting the primary care that they need at a primary care office just because it's frankly not available. And that's unfortunate. And this is not supposed to be a discourse on how to change that, but who knows, maybe somebody will listen to this and start thinking about that. So there are a lot of people who have chronic medical conditions that should be managed by a primary care provider that they're just not getting that. So we end up with people coming into the emergency room. They need refills on their blood pressure medicines. They may need refills on their diabetes meds, their asthma meds, whatever those are. And then we also get some folks who are in crisis because they're not getting their high blood pressure meds. They're not getting their diabetes meds. They're not getting the things that they need to manage those chronic conditions. And unfortunately, they progress to a point where they have become true emergencies. So we kind of get this like weird thing going on where some of them are coming in and it's not really an emergency, but we should probably help them because we can. However, we also need to caution them, hey, if you're going to be getting on blood pressure medicine, you should probably have a primary care resource to follow that. And I try to always give somebody a follow-up, even if it's to one of the free clinics or things around, because frankly, you're coming into an ER for your medical care. You're not going to have continuity of care. You may not see the same provider. I may not have all of your records, especially if you're going through several different hospitals now and then to get your medical care. And then you might come in and let's say a patient has diabetes and for whatever reason, they haven't been to see a primary care in 3 years, so they haven't gotten refills on their prescriptions of whatever the medication is they're taking to manage that. Now they've had elevated blood sugars for, we call that hyperglycemia, for several years. They may have issues now with their kidneys caused by some of their diabetic things. They might have issues with their eyes with diabetic retinopathy, or they might be coming in with a condition we call hyperglycemic hyperosmotic syndrome, where they might be having diabetic ketoacidosis, and those are true medical emergencies that we need to fix right now. Might also get some alcoholics or some people who have other substance abuse issues that are coming in, and they're coming in for they need detox. Some folks, they live on the street and they just need a place to stay when it's cold or rainy, and they come to the ER. You have to be really careful if you're a practitioner and you have this situation, because some folks I've noticed have a tendency to kind of get that guy, he's back again. Well, I've had a number of times when I've had the alcoholic patient who's coming in for their 50 millionth round of detox therapy, and now they're in atrial fibrillation because they're in the detox process where they're having some cardiac issues. They might have some electrolyte imbalances. The point I'm trying to make there is with these patients that come into emergency rooms frequently, we have to be very careful because it's very easy to be like, it's just them for this again. But a lot of these people do have legitimate medical issues. They do have legitimate limited access to care. And eventually they are going to have a legitimate emergency medical situation that I don't want to be the provider. And if you're a provider, you don't want to be the provider that says, oh, they're just here for that again, and sends them on their way. One of the other big issues we run into when we're dealing with substance use patients a lot of times is they'll come in and we won't have treatment beds available. We can hold them in the ER, and depending on the size of the ER and the resources available, that's varying degrees of success, whether or not that's a bad plan. However, a lot of these people, when they come in, if they are not a danger to themselves or others, if I feel they're not actively suicidal, if they are not, frankly, psychotic, looking like they are going to harm someone else, then I don't really have the legal right to hold them there against their will. And the unfortunate thing is a lot of people in these situations do tend to come to the ER and then check out against medical advice. We call it, they leave, even though we don't feel that they've had enough of an evaluation or gone through enough of a treatment plan for them to be successfully treated. And that is unfortunate, but that is one of the things that if we could figure out how to solve that in our system would be outstanding. Another issue we run into a lot is there's a lot of people who come into the ER who get things done. I've seen this with trauma patients. I see this with patients who get minor things done like suturing. And unfortunately, we see it with substance use patients that they just don't have any follow-up to go to. So they end up coming back to the ER for things, and sometimes they either didn't read or didn't understand their follow-up instructions, discharge instructions very well. And they may come back in with things that are not optimal but can be easily solved. They might have a scar that is worse than it would be otherwise if they'd gotten their sutures out on time, or they may have something that's progressed and is now a more serious issue just because they didn't have a good follow-up care. And that's one of the things that I would like it if our system could figure out a way to solve. And then there are some people that do use the resources inappropriately. There's not many of those, but usually you know who these people are. And unfortunately, these are the kinds of people that they may not have an issue today, but they're probably going to have one eventually. So you can't just say, oh my God, that guy again. That would be something we need to figure out how to solve in our medical system. If we could come up with a way to get them better access to primary care, that might help solve some of these issues. Primary care is not the highest paying specialty in the medical field, and that might be one of the things that is keeping some people from going into it. I know I was initially considering on going into primary care when I got into PA school, but one of the reasons I decided to go into like the emergency medicine field and initially into the burn and wound surgery field. Initially burn and wound surgery was where I could get a job out of school. And when you first get out of PA school, that's pretty important. And another reason that I decided to get into emergency medicine is the pace is pretty good. Frankly, pays pretty good. And I'm honestly doing more to help the people with primary care that really need it than I probably would be doing if I got into being a primary care provider, because I'm seeing the people that don't have access to them. There is a lot of a push in modern medicine to solve issues with costs. A lot of time they attack that from they want to go after the provider cost angle. I actually looked into this at one point, and about 30% of your healthcare costs are provider-related costs. That's people like me who are actually evaluating you. They're coming up with your treatment plan. They're deciding what they need to do. We've had a medical education Doctors, of course, have had much more education and experience than me, but that is one area of cost. But you also have about 30% for administrative cost, which is in large part due to the complexity of billing through our third-party payer systems. Other things to consider that might help us reduce some of the costs associated with medicine in general are the education costs. I went into PA school with $28,000 in the bank. I came out $163,000 in debt, which I'm still paying off $1,400 a month until I get that done. Every state I hold a license in, and right now that's 4 of them, about every other year I have to pay somewhere between $150 and $300 to get that license renewed. And then if I want to prescribe controlled substances, I have to have a DEA license in every state that I'm concurrently practicing medicine. And every 3 years, that is $888. And then, as we discussed, the admin fees associated with coding and billing and administrative overhead and other things that are way beyond the scope of this discussion. But those are some of the issues with when you go to the ER and you see how much your bill is, or when you go to medicine in general and you see how much your bill is, that hopefully that explains a little bit some of the costs and some of the areas why some things are priced the way they are. Frankly, I love doing emergency medicine. I wouldn't give it up for the world. There are days where it is super trying, but then again, it's also super rewarding. 2 things that are kind of the most satisfying is when you actually get to help someone get a interesting laceration repaired that would otherwise either have caused horrible scarring or may not have stopped bleeding if you didn't close that up. And then the other thing that's really outstanding is if you get a diabetic patient, they come in, they had extremely poorly managed diabetes, and you see them and they all tell you they're going to start managing it. But occasionally, I've had 3, I think, over the 5 years I've been practicing medicine, I've actually had diabetic patients show back up and they actually gotten their diabetes under control and started to do the things they need to do to stay healthy. And that is really cool when you get to have that and know that you really help someone truly change their life and be able to manage their chronic condition. And if you get to find a case of appendicitis, you legit saved that person's life because they went home in that burst. It probably would have killed them. Thanks again for listening today to this episode of Medical Mariner Inc. I appreciate you putting up with this podcast getting going. I hope we're improving a little bit every time. I look forward to hearing from you. Please comment, please like, please email, and thanks, and I hope you have a good day. Thank you for listening to Medical Mariner Inc. Medical Mariner Inc. is written, produced, and hosted by me, Paul Stewart. If you wish to make suggestions for content, leave me some comments, or have anything you would like for me to know, you can email me at medicalmarinerinc@gmail.com. Thank you for listening. To support the show, please give me a 5-star rating on whatever platform you listen on, like, and subscribe to the show. Thanks, and I hope you have a good day.